Thank you, Dr. Wicker. Now, I didn't wear my teach green the way you demonstrated today, but there's a little green in the tie, so
I appreciate it.
go away, get away with that. Well, gosh, good afternoon, everyone, and thanks for joining us for Teach Education Day and for this keynote presentation, the third Richard C. Very PhD endowed lecture at the Virginia Tech Carleton School of Medicine. Welcome to those here in person enjoying some lunch and those who are Zooming in as well. The lectureship was established on October 29th, 2021. At that time, when the toll of ALS had made it too difficult for Dr. Very to continue in his work, we celebrated his career in this auditorium with tributes from his colleagues and students and friends. And we were delighted that he and his family were here to hear that and experience that. At the close of that event, we announced that in honor of his retirement after joining the Virginia Tech Carleton School of Medicine on April 1st, 2008, as founding Associate Dean for Medical Education, and in appreciation of his commitment, dedication, and service as Senior Dean for Academic Affairs and architect of our innovative curriculum, that we were delighted to announce the creation of the Richard C. Very PhD Endowed Lectureship. I want to thank many of you who are here and others for helping us to achieve that endowment goal so that we can continue this lectureship in perpetuity. Rick passed away the following June after we announced this program, leaving a sense of loss for all of us who knew and loved him. Today, we're just very pleased that, as has been our tradition over the last years, that Rick's wife, Patty, is here. Their daughter and son-in-law, Liz and Brock Mutchison, are here. Granddaughters, Sylvia and Ryan Mutchison. So, hi, everyone. Nice to see you here. Yes, applause if absolutely. For me, being in this space together helps me remember other times here and brings back warm memories of Rick's life and legacy. Choosing the very lecture is no easy task. I want to thank the planning committee for their hard work creating and annually updating a list of potential speakers who are luminaries and rising stars in medical education in the US and internationally. And we are delighted that our top choice for 2024, Dr. Quentin Youmans, accepted our invitation. Dr. Youmans is Assistant Professor of Medicine at Northwestern University Feinberg School of Medicine and an advanced heart failure and transplant cardiologist with the Bloom Cardiovascular Institute of Northwestern Medicine. He serves also as the Director of Pathway Programs and Student Support within the Office of Diversity and Inclusion at Feinberg and is the Medical Director of Community Affairs at Northwestern Medicine. It's a lot for a young faculty member to be doing. He must really care about these things. Yeah, of course he does. Dr. Youmans has a passion for mentorship, building inclusive environments in academic medicine, engaging the community in all aspects of health. His work highlights racial disparities and bias in medical education and has been published in the New England Journal of Medicine, JAMA Internal Medicine, Archives of Internal Medicine, and other journals. His clinical interests are in health equity and heart failure and cardiovascular disease. His research centers on the social determinants of health and heart failure and community-engaged research for heart failure prevention and treatment optimization. So fueling Dr. Youmans' work in these varied roles is a passion for science, for humanism, and for fostering a sense of inclusion and belonging in patients, communities, and the learning environment. These are values that Dr. Very championed every day, one person at a time, with a big smile on his face. So please join me in welcoming Dr. Quentin Youmans to the podium.
Well, thank you so much, Dr. Learman. Thank you to Virginia Tech. And thank you so much to the Very family for this really warm and welcoming invitation to come speak with you all today. It is my pleasure to be here. As mentioned, I'm an advanced heart failure and transplant cardiologist, but I have a real passion for medical education and specifically how we can move from diversity to inclusion and belonging. I want to share with you that I'm going to provide some real world examples, things that I've been through. And for the trainees who might be here, things that I was able to implement even as a trainee to hopefully empower you to consider what are the things in your environment that you might want to change? And how can you take small steps to change those things in a learning environment? I first want to honor Dr. Very and his family. From what I learned, we had a really wonderful faculty dinner last night, and I asked for some tidbits about Dr. Very. And what I learned is that every Friday, he would take his team and to basically a social outing to learn more about who they were, not just in the clinical setting or in the education setting, but really who they were as people. And I think that really embodies the leadership that Dr. Very brought to this institution. And for that, I am grateful. This quote was really inspired me, and I think connected to Dr. Very. The art of teaching is the art of assisting discovery. And that's really what he brought here as the dean, and what I hope to at least impart a little bit in my talk today regarding discovery. And so, as was mentioned, I don't have any relevant financial disclosures, but what I would like to disclose is the passion that I have for several of these different topics. And so, as was mentioned, I'm the director of pathway programming and student support. And in that role, I lead a couple of pathway programs that try to help bring students who might be high school students or college students into the immersion of medicine so that they can recognize and really see themselves in the medical specialties, whether that's in physician, pharmacist, nursing, physician's assistant, really anything. We want them to get into science and really develop a love for science. I'm also the medical director of community affairs because I feel that with this work really related to health equity, you really have to include the community in as much as you can. And if you don't do that, if you don't start with that step, you're really a step behind in terms of making progress with the community. And then finally, in this last year, I've joined as core faculty specifically for recruitment. And as we think about diversifying the workforce, it obviously starts with recruitment and what the efforts that we should take in order to create a diverse class, whether that's in the different allied healthcare professionals within our system. So I want to start with a story. If you can believe it, that's me right there all the way to the left. I had a few gray hairs at that time, a few fewer gray hairs, but this is my first year of medical school. And I had a couple of friends. So those two friends there, Mike and Manuel, we were actually the only two Black men in our class of 180 in medical school. So coming into an environment where you're already kind of othered and very few of you, that creates and builds on a difficult situation when you recognize that we all are here to learn medicine the best we can. And I want to tell you a brief story about when I was an internal medicine student, a third-year medical student. So we're rotating. I had a co-student with me who was very lovely, very nice. She was a white woman student who was part of the same sorority actually as my senior resident. And they had a great relationship. So they would come together, they would laugh at the same jokes. They were friends. They developed a friendship. And when I, obviously during third year was trying the best I could to be successful and to be a great student. And so I asked my senior resident for some feedback about halfway through the rotation. I asked, how was I doing? How did she think what could I improve on? How did she think things were going? And her response was, well, Lucy's really smart, so I'm asking about my performance and how I'm doing, and her response was to mention my co-student and how smart she was. If Lucy was smart, what did that mean about me? If she's doing well, by contrast, how am I doing? And so I want us to kind of frame that in terms of the environment that we create for our learners and how we can potentially do better moving forward to create a really inclusive and belonging environment. So here are our learning objectives for today. We're going to discuss some of the tools that are available for recruitment of underrepresented minority learners in 2024. We'll illustrate ways that bias can affect the clinical learning environment and move towards diversity and inclusion. And again, I titled this talk a toolkit. So I'm hopeful that each of us will take away some really easy, low-hanging fruit things that we can do to improve the clinical learning environment for our learners. And then finally, we'll define the role of mentorship in supporting learners from underrepresented backgrounds over the span of their training journeys. It's something I'm really passionate about, and I'm hopeful to really impart to you as well. I think it's always important for us to start with the why. So what's the case for diversity? Why should we have a diverse physician workforce? Well, I think one of the primary things is when we think about the patients who we care for, disparities unfortunately persist in a number of different specialties within medicine. I'm in cardiovascular disease. We know that hypertension or high blood pressure has run rampant in certain communities. We know that my field of specialty, heart failure, unfortunately has a lot of disparities in terms of how many patients have heart failure and the outcomes related to heart failure. And we know that if we diversify the workforce, those clinicians who ultimately end up caring for patients, well, it may end up caring for more patients from diverse backgrounds. For example, there's a study that found that non-white physicians cared for 53.5% of minority and 70.4% of non-English speaking patients. We know that patients from underserved groups were significantly more likely to see non-white physicians than white physicians. And additionally, there's a moral obligation to right the wrongs of the past related to racial discrimination. So these are all reasons why we should at least consider that diversity really is really important. But if we move from diversity, how do we create an inclusive environment? So we'll start also with some definitions. So what does the AAMC define as underrepresented in medicine? So underrepresented in medicine means those racial and ethnic populations that are underrepresented in the medical profession relative to the numbers in the general population. I argue very much so that we should really try to increase the numbers of those who are underrepresented so that we can care for the patients who really need it. Those patients who unfortunately deal with disparities, whether it's in cancer care, in cardiovascular care, in rheumatologic care, and otherwise. So I love this data from the AAMC because it really does show us, okay, how are we doing in terms of our diversification of the workforce? So if we look here, we can see from 2016, this is data from 2016 to 2023, and it shows a breakdown in terms of the applicants to medical school and their racial breakdown. So as we can see, comparing 2022 to 2023, or let's start from 2016, if we look at Black and African American, around 5,000 applicants applied. And really, the numbers have stayed relatively stagnant. 2021 was an interesting year. You think about maybe potentially there was an effect related to the pandemic. And then 2022, we were around 6,000, and then there's been a kind of minus 4.3 decrease from 2022 to 2023. If we think about Hispanic or Latinx, again, numbers were around 5,000, and they increased in 2021, but then have kind of come down to 6,000. And then comparing that to our white applicants, we see that the numbers have been around 30,000, 27,000, and then to 26,000. Again, there's a decrease from 2022 to 2023. So those are applicants. When we look specifically at matriculants, we see specifically for Black matriculants into medical school, there was about 1,700 here, and that also has sort of stayed relatively stagnant, although has increased by a couple of hundred to 2,300 in 2023. And we compare that to, for example, Hispanic 2,900 and for Black and 11,000. So these numbers have stayed relatively stagnant over the last several years. The worrisome thing is what's going to happen after the Supreme Court decision last year. And so I went to Brown University for undergrad, as was mentioned, and there's a really striking set of circumstances that have just occurred in the last few months. There was a 40% drop in the Black freshman class at my alma mater, at my institution, directly related to the Supreme Court decision about how can we choose our classes in terms of the proportion of classes and the proportion of students who come to our classes. It's very interesting because we don't yet know what impact this will have on matriculation into the health sciences, but we know that there's likely going to be an impact. So what can we do about it? How can we change? How can we adapt to what now may be a mandate related to the government in how we diversify our workforce? And I think the way that we respond is that we must and we need to transition to a holistic review process. Think about, our institution here. Think about Virginia Tech. Think about Carilion School of Medicine. What are the things that make an amazing physician or clinician at Virginia Tech? What are the things what are the aspects and components? What are the themes that you want for a good doctor, a good pharmacist, a good nurse? And how do we ultimately choose a class that is in line with those themes? Holistic review is actually the best way for us to do that. So how does AAMC define holistic review? It's a flexible, mission-driven approach to recruit and assess an individual's competencies by considering their experiences, attributes, and metrics in order to select applicants who will best contribute to the program's unique goals, learning environment, and the practice of medicine. The core principles of holistic review we'll talk about that are outlined. That's the ultimate way for us to decide who's gonna be the future? How are we gonna make up a class that is diverse in every way? Again, that is in line with the themes that's important to the School of Medicine here. There was a big change that we all know about in 2020 that makes holistic review really one of the most important things we can do. And that was the shift in our step 1 scoring in medicine to pass fail. Why was this shift important, particularly when we think about diversifying the workforce? Who does well on standardized test scores, right? That's the big question. It's those students who have had access to the preparatory coursework that's necessary. It's those students who from day one were able to learn how to take the test and learn how to do well on the test. And one of the things we know is that there's not a big connection between the scoring on step 1 and how good of a physician a doctor ends up being. There's no connection there. But unfortunately, for many years, we used step 1 and we used the score on step 1 to determine what specialty a person could go into. That doesn't make any sense, right? A test that was not designed to do that was used to understand whether a student might be able to go into dermatology or orthopedics versus family medicine or internal medicine. And now, one of the things that we argue in this perspective piece is now that this is pass fail, it opens up a world of opportunity. And as we know, with every opportunity, there comes challenges, but a world of opportunity for us to steer clear and get away from just test scores to how can we really assess our students as they're applying. And I think holistic review really does that. This is some interesting data from the AAMC, and it looks like the impact of holistic review in terms of the makeup and the diversity of classes. And what you can see is schools that use many holistic review elements actually increase their diversity. 81% of those schools increase their diversity. 16% were unchanged and 4% decreased. And down at the bottom there, total schools using holistic review, 72% of those schools saw an increase of diversity. So this study shows that holistic review can successfully help with diversifying the workforce. And I think that's great for us to consider, but I want to show you what we do specifically at Northwestern. So as I mentioned, I'm one of the core faculty in our internal medicine program. And so how do we actually do this in terms of logistically deciding on how we can choose our candidates? So we have actually 5 different domains that we assess. One being clinical competencies, and that's the thing is the foundation really has to be clinical competence, right? We're not trying to choose folks who are not going to come and succeed in medicine, but we want people to have the underlying foundational clinical competency. But what are the other things that we assess? Exceptional experience in community service. So choosing candidates who have been involved with and engaged with the community, recognizing that brings a huge amount of value to the practice of medicine. Leadership potential in research. And again, that's potential, right? So these are students who have, Adam Grant has this great book called Hidden Potential. So you want to identify those students who maybe because of their background haven't yet achieved, but they have the potential to have huge impact in research. Leadership potential in medical education. Who are going to be the future medical educators who are going to give this talk, this very lectureship for our students in the future and for our institution. And then lastly and importantly, resilience factors. What are those factors and those barriers that they've gone through and they've been able to overcome to get to where they are? That shows grit. That shows that if they are approached with or have to tackle a really difficult scenario or situation, they're going to be able to get over that because of the resilience factors that they have had. And so we score these out. We have a huge group of 20 faculty members that actually review all of our candidates. And so it is a heavy lift because you have to go through and you're not just relying on scores, You can't really just decide based on a level of score that you're not going to include, but you're really going to really review every applicant and learn who they are and what they will bring to your institution. And it helps you decide who will you interview. You're going to learn more about them as you interview them and really see how can they contribute to the environment that is at your institution. So I really focus on holistic review in terms of how we diversify the workforce. But I want to circle back here because, the experience that I had with Lucy, I don't think it is, unfortunately, an experience that many of us may face in the learning environment. So we should really name what were some of the things that I felt and experienced as in that environment. You could consider that a microaggression, right? Something very small that kind of cuts at you. And if it happens once, it's not too bad. But if it happens multiple times, it does grate at you. It contributed to imposter syndrome, particularly because I was being compared to my classmate. And it's just these feelings of, do I really belong or am I an imposter here? Can I gain confidence here? Can I succeed here? There was stereotype threat, recognizing that there was probably a stereotype that was aligned with who I am and my identity that might have contributed to how she was treating me. There's homophily, and that's an aspect of, do you feel connected to the people? Do you feel like you're aligned with the people who are in your training environment? There's this concept of tokenism as well. Being one of the only Black residents in the institution, am I only there because of that? Or am I there because I add something to the institution, I add value? And then obviously there's this whole concept of implicit bias, which thankfully in the last 4 years, we've been exploring increasingly and recognizing. But I think all of these play a role in the impact that it has on trainees who are underrepresented in medicine. And we should be able to not just recognize it, but also name it and recognize the impact that it can have. So what is implicit bias? It's an unconscious preference for a specific social group that can have adverse consequences. And one of the things we have to recognize is that we all have them, right? It's something that we all have, and we shouldn't really place a value judgment on whether it's bad or good, because oftentimes we use our implicit biases to protect ourselves as well. But the first step is for us to recognize that we have them so that we can see when implicit bias might be playing a role in our assessment of learners. And so that happens both in recruitment, but then also in our assessment of the performance of learners. And so the first step is to recognize that we have our implicit biases. And then the next step is, once we recognize that we have them, we have to understand how we can mitigate implicit bias. So this is one of the things I want us to take away in terms of our toolkit. So what are the tools that we can use? What are the ways that we can do to actually minimize the implicit bias that we might bring to our learners? One is reflection. So think about, even just in the last week, I'll invite you to think, what were some moments where maybe in your gut you might have felt where an interaction didn't go well, or whether there was a body language that might have been off, and just consider and reflect, might there have been an opportunity where potentially implicit bias played a role in that interaction? Don't stereotype, but individualize, right? Oftentimes we might meet a person, and this is whether it's a patient or a learner, and we immediately come to stereotypes. But we have to really individualize and consider, what has this individual gone through, and what are the things in their life that we might be able to latch onto so that we don't have bias against that person. Take the perspective. So perspective take. Try to consider what are the life experiences that they've gone through and really empathize with those life experiences. And that can minimize implicit bias. And then lastly, and this is really important because implicit bias happens when we're in our day-to-day and going through very quickly. We have 15 minutes to see a patient. We have 5 minutes potentially to assess a learner, but slow down, because that's where implicit bias really plays a role. It's that quick switch. And we use that quick switch and that stereotyping to assess people. But if we slow down, then we can take these other steps, including reflection, and make a difference. Now, one of the things I wrote with actually a resident trainee at our program, this is now our recruitment season, right? So I'm sure here and in many places, we're actually using the virtual recruitment process to assess people. There's a lot of positives to that, right? Trainees don't have to fly everywhere throughout the country. They can really access things very easily. but it also is an area that can be ripe for bias. So what are the things that we can take away in considering our recruitment processes, specifically in the era of virtual recruitment? These are some of the things that we recommend for our recruitment teams to consider. One, we encourage implicit association tests, recognizing that, again, that recognition of the implicit bias that we might have can at least begin the work of bringing down the bias. Develop structured interviews with a standard rubric. That way, we are assessing every applicant who comes through the door in the same way with a standardized rubric. Very, very important. Utilizing many multiple interviews, because we recognize if we have dispersion in the amount of folks that people meet, then if there's one person who's bringing a certain level of bias, then we have a little bit of dispersion and dilution, if you will, of that impact on the assessment of that applicant. Blinding interviewers to applicants' cognitive application data. I think can be challenging, but it's actually really important because that way that person has the opportunity to show you exactly who they are and to consider the really humanistic aspects of them outside of some of the cognitive data that you're still going to use at the end of the day when you're assessing the folks who are applicants, but it's helpful to do that during the interview. Encouraging virtual meetups for underrepresented faculty, staff, and applicants. Again, this comes to this point of how do you create an environment where folks feel comfortable? And that is required, and in order to do that, it's required for you to make sure that they have opportunities to meet the faculty, to meet the staff, to meet the students who are here so that they can understand exactly what environment they're joining. And finally, evaluate diversity representation at the end of the interview cycle to identify areas for improvement. I think number 6 is probably one of the most important things. You don't want to start an initiative and just have it be that, right? You have to constantly be iterating and trying to improve and trying to work. And that takes an assessment of the processes that you have in place and a really intentional change to make that happen. So that's recruitment. But I think, considering bar graphs and thinking about experiences are one thing, but I wanted to share a very personal experience that I had in my learning environment because it had a really huge impact on my training. So as a resident, I was taking care of a patient. And I think if all of us who've had patient care experiences, we know that unfortunately there could be a spectrum in terms of how folks are treated. I had a patient who came in who was complaining of chest pain and demanding IV narcotics to help with his pain. And the team had issues with trying to minimize the amount of narcotics, but treat the pain, and to do the effective workup that was necessary to determine, did he really have an underlying cardiac cause to his pain? So I came on as the resident covering in the afternoon, and the patient had his angiogram procedure in the morning and was not found to have any cardiac cause. So the angiogram was clean. He had non-obstructive coronary artery disease. So he was ready for discharge. So I went in with my intern. I'm the senior resident, had my long white coat on, and we said, Mr. J, your angiogram was clean. You're ready for discharge. And he said, I'm not going anywhere. And so we had kind of a back and forth discussing why. Thankfully, clinically, he didn't have a reason to be in the hospital. And things escalated rather quickly. He started screaming and berating us. And I turned to my intern and I said, we should get out of here. We should call security. This is not an environment that's safe for us. And he immediately turned to me and he said, I'm not playing your fucking nigger games. And it's one of those experiences that as someone who is from South Carolina and, obviously a Black person, I had never had that experience or that exposure. And when you think about what impact that has on you and how much time you've spent trying to learn to take the best care of every patient, and you're belittled to the point of just being a person of a certain skin color, it has a huge impact. So I left the room and I talked to my attending doctor, who was the cardiologist who's on service.
And he didn't do much, to be honest with you. He said, well, you shouldn't go back in there, but we'll continue to take care of it and I'll handle it, don't worry. On the flip side, I called my program director, who is very caring, a great educator. And he took me into his office and we did a huge debrief on that experience and that exposure. He said, first of all, I'm sorry that happened. And he said, secondly, we need to make sure that we have policies in place that where people can speak up and speak out if that happens. One of the things I learned over the course of this experience is that this is unfortunately not uncommon. And whether it's related to race, whether it's related to ethnicity, whether it's related to sexual orientation or identity, learners in the learning environment have things that happen to them that tear away at their confidence and at who they are, because it's part of their identity. It's something you can change. And when you think about all of the expectations for our learners in terms of learning to be a good doctor or pharmacist or nurse or anything, that's hard enough as it is. But when you add in these macroaggressions, it makes it really hard to be focused on how do you become a good doctor. And so this was my experience. Many go through this experience. So I want to empower us to consider, how do we respond in these bias scenarios? How do we really come to the aid of our learners, and how do we protect them in a way from these types of experiences? So what are some of the challenges?
We're all there to take care of patients, right? So one of the things is balancing patient autonomy and ethical principles of justice and malfeasance. We want to make sure that we're doing the best we can to care for patients, because many patients, obviously, when they're in the hospital, they're at their worst. They're having their worst time. But how do we balance taking care of the patient and then also caring for our learners? We all live with this, right? In medicine, first do no harm. But then we also have to consider, how can we first do no harm to the patient, but also protect our clinicians? There's this big concern about building lasting patient-clinician relationships, and whether if we speak up and speak out, will that hinder that therapeutic relationship that the team might have or that the individual might have? There's a perceived lack of support from colleagues, particularly if there's not a policy in place or at least a foundation of expectation for response. And then there's risk of poor patient satisfaction scores. We all are beholden, right, to the likelihood to recommend, right? And how does something like this affect a patient's experience within the hospital system? So I have a few recommendations in how to respond to this. The first, and this was by Justin Bullock, actually, when he was a trainee, and ultimately went into nephrology, published in Academic Medicine back in 2021. But I think this is a really helpful framework in terms of how do you approach caring for your teams in a learning environment. And the first is a pre-brief, which I hadn't thought about, but I think it's a really great idea. So when you are initially exposed to your team and starting rounds with the team, considering a pre-brief with your learners in terms of, how would you like, if something happens and a microaggression happens, what would you like to happen? How would you like for this team to respond? I think starting with that is important because, one, it recognizes and sets the foundation that this is something that you care about, and this is something that we do in terms of protecting the team no matter what. And then two, they actually tell you. So folks will tell you, I would prefer that you step up or step out or speak out, or they might say, I would prefer to not do anything in the moment, but to talk about it later. You kind of get that opportunity to hear from the learners and to explore with the learners, and it sets that foundation. And then it goes through multiple steps about recognizing the microaggression, analyzing it, considering their response, and then ultimately checking in immediately afterwards. I think the easiest model in terms of response, though, is this SAFER model. Step in when you observe behavior that does not align, and this was published at Mayo Clinic, but it includes every institution, does not align with your institutional values. Address the inappropriate behavior with the patient or visitor. Focus on Mayo Clinic values such as respect and healing. Explain the expectations and set boundaries with patients and visitors, and then report the incident to the supervisor and document. Very easy, very direct, and it's actually something similar is what we put into place in terms of a policy at our hospital after my incident. Unfortunately, it's something that our learners go through, but I think it's so important for us to consider what are the policies that we can put in place after something or potentially even before something happens to make sure that we all feel empowered to stand up and stand out for our learners. And that's, again, protecting what our learners should go through. These are some of the other challenges that learners who are underrepresented in medicine go through. And this was published related to medical students and residents and fellows, but I would argue that this is probably true for all of the learners throughout the health system. There's a lack of support potentially. There's discrimination and harassment. There can be lack of cultural representation, lower satisfaction in the clinical learning environment. We talked about episodes of microaggressions and bias, pressures to be ambassadors for their race, and then trouble with professional and personal identity. Each of these are very defined. But I think if we recognize that these are problems and these are issues that those in our learning environment face, then we can make targeted initiatives that can respond and address each of these. And I'll give you an example. So as a cardiology fellow, I'm a cardiologist. As fellows, again, I think empowering our trainees to consider how they can even impact their environment is really important. So a couple of colleagues and I wrote this, how cardiovascular disease fellows can promote diversity and inclusion in cardiology. And we were very specific about the strategies that we can use. So the first is, that UIM trainees face barriers to success on teams. So what can you do as a learner to try to help with that? The first thing is lead diverse teams with intention. Review expectations from the beginning, facilitate goal setting, and minimize rivalry among trainees. These are low-hanging things. These are things that we can do from the outset to make sure that our teams feel supported. Mistreatment during clinical care is common. So again, that part of responding to bias and mistreatment, making sure that we step in if we do see it. UIM trainees lack adequate mentors and sponsors. This is a conversation that I've had over the course of the day today. We should be mentoring and sponsoring aggressively for our students and our trainees. So connect diverse trainees to mentors, involve trainees in research projects, provide feedback to the medical school and the residency leadership, and then serve as a resource for our trainees. I'm on the editorial board for a journal of cardiac failure. And one of the things that we do is we actually look at the author block for the projects that are submitted to us to be published. And we look for diversity within that author block. I think it requires all of us across the health systems and across even at the journal level to consider diversity and how can we really impact change in terms of our mentorship. And then lastly, as we know, and as many workforces do, there's a lack of cardiology workforce diversity. And so how can we advocate to the leadership about being outspoken about diversity within the workforce? These are, again, are low-hanging fruit, things that we can do today to really diversify and to create an inclusive environment. And I want to finish up with something that I am very passionate about and have done here have done at Northwestern, and that is support through mentorship, because I think mentorship is the key to creating an inclusive environment. So why is mentorship important? Mentorship in academic medicine aids in professional development, career guidance, specialty selection, and research advancement. You really can't get to be a cardiologist or an advanced heart failure cardiologist without the appropriate mentorship to get there. Participating in mentoring relationships associated with increased job satisfaction. So there is something there, obviously, for the mentor as well. And folks who are at academic centers and in academic medicine, they recognize the power of mentorship for themselves as well. And then trainees in medicine identify mentors by more senior peers as having a positive impact on their well-being. But how do we create really the infrastructure for mentorship? And this is a saying actually that I coined as a resident that I think is so true. You're never too old to need a mentor. And for the trainees who might be listening, you're also never too young to be one. So consider that you can help, no matter what stage you're in, to be a mentorship for those who are younger than you. And to that end, I want to share with you our mentorship program called Strive, which is the Student to Resident Institutional Vehicle for Excellence. So the foundation for Strive is really grounded in this, which is that there's so many silos that exist in the academic center. The medical school is in one place, the residents and fellows are in another, the hospital is in one place, the classroom is in another. And so when do you really connect and how do you really connect the two? And I would argue that peer mentorship specifically, and that's near peer mentorship, is the way to sort of bridge the gap. And that's what we did with our program. We connected residents and fellows with medical students in the name of mentorship. And I think it's really important because our program, it was specifically resident-led and trainee-driven, because I think that only residents know the trials and tribulations that they go through and how best to share it with their near peer partners because they've just gone through the medical education process. They've just been medical students. So they know they're very much in tune to the challenges that are being faced by those who are underrepresented in medicine. So this is our process map for Strive. And this is how we sort of provide our mentorship program. So we identify those residents and fellows who are underrepresented in medicine, and that's by self-report. We invite participation in Strive and for folks to actually be mentors in our program. And then we identify those students who are also underrepresented in medicine through our Office of Diversity and Inclusion. And we connect them through various programming that occurs throughout the year. We started this program in 2016. We had some hiccups as you might be aware of during the pandemic. We had the transition to complete virtual. And now we're back to in-person. And these are our pillars of programming. So we review the curriculum for our students, and that includes, and it's really great because, for example, as a resident, I was interested in cardiology and I wanted to take care of patients with heart disease. And so during the cardiovascular module, for example, I would meet with the students and review the cardiovascular module with the students. So that's where the curriculum review sessions come into play. So residents who are in psychiatry or in neurology, really they bring with them their expertise to the curriculum review session. So they get a lot out of it because they learn how to teach and how to be mentors. And the students get a lot out of it because they're actually able to learn and review what's going to be on their testing. So it ends up being great. Panel discussions. M2 is going into M3. There's a lot of, we were discussing this earlier, there's a hidden curriculum about what's expected when you get to M3 year in terms of medical education and how you should comport yourself, how you should behave on rounds. And so we have our residents who were just medical students teach our students what's expected of their performance in terms of whether you're in medicine or in the OR and surgery. And it really is a powerful connection that they can make. And then finally, and I think importantly, social events. So getting to know team members outside of the medical environment, what's important to them, what drives them, what's their family life like. You really cannot put a price on how important that is in terms of building an environment where you really drive towards inclusion and belonging. That part is key. These are some more details in terms of exactly what we did with our panel discussions and with our social events. This is published in JGME, so if you're at all interested in learning more about how we were able to effectively create this, I think it's important. But if you think about, this is one example, right? But if we think about our pipeline programming, considering medical students to undergraduate students, residents and fellows to medical students, even junior faculty to residents and fellows, this is something that we can do across our system to make sure that folks feel supported and that they know they can be successful. And again, it comes down to learning what drives people and we're learning what impact they would like to have and supporting them to get there. One of the things we thought was very important was to make sure that we have a lot of diversity in terms of the subspecialties. And so we had great representation in our Strive program. And just like anything else, as I mentioned, you don't want to just start something and let it flourish, but you really want to study it to make sure that you're having the impact that you want to have. So we did a small survey study on the resident mentors about attitudes. And as you can see, many agreed or strongly agreed that Strive made them a better mentor. It helped them deal with the challenges of underrepresentation in medicine. that they benefited professionally from participating in Strive, and whether they would recommend this for medical trainees who are underrepresented in medicine. So we were very pleased to see that the residents actually got a lot out of, as well, the mentorship model that we created. But I think it's so important also to hear the voice of the trainees, the voices of the residents directly. So one said, Strive is an outlet to discuss the unspoken rules and experiences of being a minority in medicine. Again, this whole concept of a hidden curriculum, if you've never been exposed to it, you just don't know what to expect. And so having folks who can share with you what that expectation is like is really hugely important. I've enjoyed getting to know the medical students in Strive. They were excited to learn, very engaged, asked great questions. There were many challenges I had to navigate on my own as a medical student. I simply didn't know how some things worked, and I didn't know who to ask. Isolation, right? I didn't even know who to ask. So providing that infrastructure to know who to ask. I feel like I'm having a meaningful difference in their lives and helping them feel confident with their residency. And then, I think this is a really great voice of the medical students. So this was a student who participated in the program. He said, finding Strive was one of the defining moments of my medical career. Coming from a rural town in Brazil and then a smaller undergraduate institution here in the United States, I was equally excited and intimidated to be starting medical school at a highly prestigious, large academic center such as Northwestern. The mentors at Strive helped me feel like I belonged here and have supported me both academically and personally to help me reach my full potential. I'm forever grateful to each of the residents who took time from their busy schedules to help me navigate the overwhelming undertaking of going through medical school as an underrepresented minority student. I hope they understand the magnitude of the impact they had on my personal and professional life. Something small, something that is a few experiences or exposures where people feel, they really feel like they're being supported. It can have a huge impact, and it can make for something where you might not feel like you can be successful, but it can make you feel and understand that you can be successful. I think if we create these environments for our trainees, then we'll be all the better for it. One of the things that we argued in this piece was just, identifying and addressing the sources of discrimination and bias are important. We have to do that. But then creating spaces like the ones in Strive through a model of near-peer mentorship should be a consideration for academic centers. While we are trying to tackle the episodes of discrimination and bias that exist, we can, in the meantime, support our trainees with programs like this. To end, what are some of the other ways that we can consider building inclusion and belonging in our training environments? How can we start today? The first, which has already been done here, is to commit to diversity, equity, inclusion, and belonging. There's a commitment that is already there in me being here to give this talk even, and so how do we build on that commitment? Collect and make transparent our climate data regarding this. So if we need to understand what's our current state in terms of surveys and climate data to recognize where the issues that we might need adjustment. Act as personal navigators. So this comes back to really taking ownership in terms of mentorship for our trainees, creating safe and open spaces for dialogues we've talked about. And then this is really important, build into the budget that we value this. Money talks, right? So until we put our money where our mouths are in terms of, it's just something that's important to us, we will still not make the headway that we need to make. And then longer term, we should define and implement diversity, equity, inclusion, and belonging competency milestones. So just as we have milestones for all the other things we do in academic medicine, this should be part of who we are and what we do in terms of what do we want to achieve. Implement practical training for our faculty, create longitudinal equity, anti-racism, and anti-oppression curriculum for our trainees. And then most importantly, I think, hold yourself and your program accountable, making sure that we're considering at every step with every year, are we doing everything we can to make headway in this really important environment? So these are the things that we covered today. I want to thank you so much for your attention and for your engagement. And I'd love to take a few questions. I'll highlight that this was just about a month ago. And this was now year 8 of Strive. These are all medical students and residents who are part of our mentorship program. And again, you see the smiles. It's about creating an environment that is safe and inclusive for all of our trainees. So thanks so much for the invitation, and happy to take questions.
Thank you so much, Dr. Youmans. That was amazing. And fortunately, many of us have not had to endure the same level of feelings of not belonging as you have described here. And your personal experience is so powerful and meaningful. Thank you. And the practical ways you've shown us and guided us to be able to help our colleagues and our learners to not have to face those feelings of not belonging. So what sorts of questions can we ask our presenters?
Thank you for your talk. It was really enlightening. I'm really impressed by your Strive program. I was kind of curious, since you've been having this program since 2016, have you kept track as far as like your mentees? Have they gone on to have a more likelihood to become mentors themselves within this program or in other institutions or wherever they happen to be?
Thank you for asking that. So the question was about, whether the mentees have gone on to be mentors. That's something that we want to assess, actually. So that's like the next step in terms of our assessment, because that's one of the thoughts I have, is that I think there's this whole concept of paying it forward, right? And with a program like this, they've gotten a lot of benefit out of. Anecdotally, I've had residents come to me who were medical students at Northwestern, and they've actually asked for advice on how to start something like this at their institution. So I know that there are a few who are thinking about that, but I think looking at it in terms of a more systematic way would be so important. And I think the other thing is that I'm hopeful that residents and fellows who are mentors in this are also more likely and more inclined to continue that mentorship as they go into their faculty roles as well. So that will be another additional thing to look at, but I think it's so important. And at least anecdotally, I think the answer is yes. Thank you.
Quentin, great to see you again.
Yeah, good to see you.
Boy, so much. I've got a couple comments and then a simple question. First of all, this was a phenomenal discussion. I wonder, where were you when I was a medical student at Northwestern? Because I needed this program. Medical school is scary, and that transition to second and third year you discussed likewise. So congratulations on taking on a very difficult conceptual challenge. And I suspect you're going to have great success with that. To follow up on one of the comments made earlier, telling your story and hearing stories, we have narrative medicine here, and I think the impact and power of that is really, really important. And we all have our own stories that I think tell so much more than understanding what implicit bias is and how do we identify and manage microaggressions. All of that stuff critically important, and we've got to do a much better job at that. So I really applaud you for sharing that story, and I would challenge others here in the School of Medicine at Cardiology Clinic to share their stories of what has happened to them, either personally or professionally. And I strongly believe that both are intertwined and are important, because we take our personal life to work and vice versa. Mm-hmm. The question I have for you, so I have a daughter who's a medical student, and you talked us through the changes in step one and how that may have some impact, either positive or negative, in terms of differentiating what professions underrepresented students in medicine may be able to achieve. But step two is still scored. And I think we all know that what residency training programs are doing is they're looking at step two now as a surrogate for both what step one used to be and what step two used to be. As a matter of fact, I distinctly remember as a medical student that step one was the test. Mm-hmm. If you did not succeed at step one, you're relegated to a different selection of residency training programs. So I wonder, one, do you foresee or do you know of any movements towards changing the step two methodology to what step one looks like? And, I also agree with you on holistic review as a solution, but it is very, very difficult to implement. And not that program directors and departments don't, or schools of medicine, they want to do this, but I'll tell you, as a former department chair, to provide the amount of release time for my team to properly perform holistic review was completely unaffordable. and unreasonable.
Yeah.
So I think there's some real headwinds and challenges there, despite the fact that it makes sense and we know it is best practice. So if you could maybe comment and respond to some of those things.
Thank you. That's hugely important. So the first comment about step 1 and step 2, I think that you're absolutely right. And even students now, they're deciding to take step 2 earlier so that they can have the score on their application before they're considering, applying to residency. So this is hugely important. I think that the direction is likely going to be that step 2, this is just my opinion, that step 2 also goes to a pass fail. And I think that there are challenges in both ways, because at this point we use step 2, we use some test scores to exclude some of our applicants. And to your second point, it's almost impossible to have a large enough workforce in terms of faculty to review in depth enough what needs to be reviewed to make these assessments. I think what we're going to end up doing, it's early now, right? But I think AI and tools like that are going to be able to help us make these determinations better in the future. But it comes back to, what do we think? What's important to us? And what do we think, or what do we invest in? I guess is the big thing. Right now, I'll tell you what we do, and it's sort of almost like a hybrid. I think we get like 4,000 applicants in internal medicine. So it's really hard, even if you have a group of 20 or 30 faculty members, to review holistically 4,000 applicants. So we do a hybrid scenario where we still have some of our older system, and that helps us determine a large proportion of our applicants in terms of who's going to get an interview. But then those folks who would not otherwise have been chosen, it's a smaller pool now, and we do our holistic review on that smaller pool. So we want to make sure that we're not missing, in terms of like, who are we missing from that initial evaluation? And we actually have found that we're missing some really talented folks, right? And when we're just cutting off of based on school they went to and the scores that they had on, step 1 or step 2. And so I think no system is going to be perfect. And I think as we're going towards trying to be holistic, there are like smaller steps that we can begin to take, incorporating holistic review, even if it's not in everyone. But I think ultimately we're going to have to find a system that meets somewhere in the middle, because just realistically, as you're talking about, it's going to be really hard to go through every application in a fashion that respects everything that they've gone through. Absolutely.
Just a quick comment on holistic review and step 2, and then a question for you. First, with holistic review, we're in that 16% of institutions that have implemented most of the elements and have not moved our diversity numbers. And as we retrospectively, we can't prospectively do this, but as we retrospectively look at our underrepresented groups, our diversity groups, through who applied, who completed a secondary, who was interviewed as in our MMI format, who has made offers of admission, we see the good percent representation by our diversity groups at every stage through the process. So this holistic review process is doing well. It's in accepting offers made is where we see the drop off. And then we get into the questions around how much of it is financial, because we don't have the deep endowments and we have no in-state tuition. How much of it is something about environment in the community or elsewhere that might be responsible for that. But I want everyone to know which sort of category we fit into in that framework. With respect to step 2, I think you mentioned this too, the unintended uses of a licensure exam and the secondary market for those. And although step 1, pass fail, goes back to when it used to be pass fail, when I took it many years ago, step 2 has all of these secondary marketing benefits toward something that many consider important in resident selection. For all of the failings and all of the narrowness of looking at a multiple choice score, it still predicts another multiple choice score, board pass rates.
Yeah.
And so that's where folks who really want to get rid of it and make it pass fail are stuck in terms of managing what other test would come up from the specialty board or another organization to replace step 2 as another MCQ to predict board pass rates and failure. But I hope it's an ongoing discussion from this INCUS group, and hopefully they'll figure that out. My question for you had to do with this really important points you made, that the more we listen, the more we create opportunities to hear what's going on with the narratives and stories of what folks are facing. The more we realize that, yes, there are patients' bills of rights that are posted on the walls of many hospitals. What has Northwestern Medicine done to create another set of rights and expectations for patients that acknowledge that the staff of the hospital also has a right to be treated with respect? So how did was that in place at Northwestern Medicine when you were training, or is it in place now?
Thank you for the question. So that is something that actually came out from my experience, because my program director was also the vice chair for education in the Department of Medicine. And again, just a very supportive leader. And so we actually went to the hospital, and there was not a policy in place in terms of the expectations for the response in that type of scenario that now exists. So, and we were talking about this earlier with some colleagues. It's not enough also to have a policy in place that then gets placed into a folder and like it's there, but it's not implemented. And so how do we really realistically implement these types of policies and educate folks that this policy exists? And so what we've done is we built it in, at least in internal medicine, that there are some didactics that go on for the faculty members prior to starting rounds. And part of that is the expectation setting around responding to these types of things. And so we created a policy that lives at the hospital side, and we have tried to build it into the education so that it hopefully at some point just becomes part of the culture. But it's definitely a work in progress. Yeah, obviously culture change takes time. And in the meantime, it's about educating and policy change. Thank you.
Thank you so much, Dr. Youmans. Thank you. Congratulations on all the outstanding things that you've done at Northwestern.
Thank you.
Thank you for bringing those experiences to us, and for your personal experiences as well as your professional experiences.
Thank you.
Did you have other things to say, Dean Mehrman?
I have a little something over here. And we hope you take things away from your time with us, your warm memories of a good meal.
Yes.
Some wonderful conversations.
Absolutely.
And being here together to celebrate the legacy of Rick Barry. And I just know he'd be smiling down upon us to see you so comprehensively and efficiently cover so many important aspects of in creating a learning environment that embodies belonging and inclusion and opens up a space for people to talk about their lives outside and inside of medicine and all those wonderful things. But we also have one of these.
Oh,
Okay, this is our frame certificate for you to put on your wall if there's any room left on your wall. So I know you have a lot of things on your wall
absolutely.
to commemorate your being here with us today.
Thank you.
And please accept this with our hearty thanks and congratulations.
Thank you so
Thank you
much.
so much for being here.
Really appreciate
And
this.
let me
Thank
hand
you.
this to you. We have a little photo op.